Hello there, welcome to my new video. In this video, I'm going to talk about Goodpasture syndrome versus Wegener's Granulomatosis versus Churg-Strauss syndrome. I'm Dr. Shariful Halim, and this is part of a lecture series based on the respiratory diseases. So I have already made some videos on some conditions such as interstitial lung disease, especially idiopathic pulmonary fibrosis, acute respiratory distress syndrome. I've also made a video on histoplasmosis, so if you have any confusions, please check out those videos. In today's video lecture, we'll be focusing on the diseases that I have already mentioned, and I will first discuss a case with possible differential diagnosis and how to actually differentiate them, followed by a detailed discussion on Goodpasture syndrome and the other disorders. I will provide the common presentation, the basic pathophysiology, and I'll also talk about the investigations and what are the best investigations and what are the first initial investigations. Those are the questions that are common in USMLE, step 2 especially. And I will also talk about the treatment options and when to do what treatment. And that's all. So without further ado, let's get started. This is our case. A 30-year-old man presents with dyspnea and hemoptysis, and this has been present for last 2 weeks. He also complains of passage of small volume of urine and probably has hematuria, and this has been present for last 2 days. So we have symptoms of two systems, a pulmonary symptom and renal symptoms. So they might be isolated or they might be related. There are many differentials to think about. And one of the common differentials would be Goodpasture syndrome, Wegener Granulomatosis, and some other disorders which might also involve lungs and the kidney. For example, infective endocarditis can involve the lungs and kidney, but it will have some other specific features. Tuberculosis can involve lungs and kidney, but it has specific features. Let's go through the negative history to exclude the possible differentials. So we take history of headache, nasal discharge, obstruction, and earache. Those are the histories that are present in patients with Wegener granulomatosis, but this patient does not have those. So there is no involvement of the upper respiratory tract. There is no history of fever, weight loss. So fever and weight loss are common in tuberculosis, but the patient doesn't have them. There is no history of arthralgia. Arthralgia is a non-specific finding which can be present in multisystem disorders such as Wegener granulomatosis and other vasculitis. There is no history of chest pain, orthopnea, or paroxysmal nocturnal dyspnea, excluding any cardiac disease. The patient doesn't have any history of smoking, so the cough and the productive sputum is probably not due to bronchitis. He also didn't have any history of asthma or other respiratory illness. Excluding asthma or taking history of asthma is important in establishing a diagnosis of Churg-Strauss syndrome because in this disease there is commonly a concomitant asthma attack. And there is no history of contact with tuberculosis patient. Obviously, this history is important, but sometimes some of the patients does not give the history but still gets tuberculosis. Okay, we have other important findings. The vitals reveal that the patient has tachycardia and tachypnea, but temperature is normal and the blood pressure is also normal. Examination of the lungs reveal bilateral crepitations. And chest X-ray is also done, which reveals pulmonary infiltrate. Obviously, a patient with um, hemoptysis and shortness of breath must have chest X-ray and other investigations, including sputum, but we are just mentioning the most important ones. So chest X-ray has been done. It shows some pulmonary infiltrates. This might suggest many things like pneumonia. It might suggest other inflammatory process. So it's very non-specific. Serum creatinine is increased to 2.6 milligram per deciliter, which suggests the patient developed AKI. Obviously, the patient has a high color urine, so we must do an urinalysis, and it reveals an active sediment, meaning the patient has dysmorphic RBC with RBC cast. It suggests that there has been glomerulonephritis. Okay, so we got the case together. If we summarize the case, the patient has lung involvement and renal involvement. And the lung involvement is probably due to some inflammation which led to hemoptysis, so meaning that there has been bleeding in the pulmonary system which came out as hemoptysis. So there is pulmonary hemorrhage. And there is also hemorrhage from the kidney, probably due to inflammation in the glomerular apparatus, so glomerulonephritis, which led to leakage of RBC, which are dysmorphed or morphologically altered and also form some cast. Okay, so inflammation involving lungs and kidney, a classic pulmonary renal syndrome. That's why our most likely diagnosis should be a pulmonary renal syndrome, a pulmonary renal syndrome, most likely Goodpasture syndrome, which is more recently named as anti-GBM disease. GBM here means glomerular basement membrane. And our differentials would be Wegener's granulomatosis, but it's less likely as the patient does not have any upper respiratory tract symptoms. The patient also doesn't have any systemic complaints. Wegener's granulomatosis is um, is a disease of the system. It's a systemic vasculitis, so it should have systemic symptoms such as fever, weight loss, sometimes arthralgia, sometimes involvement of the nerves and muscles and skin leading to purpura, etc. And it's also very unlikely to be Churg-Strauss syndrome, as we have mentioned. It's also a systemic vasculitis, so it should have systemic symptoms as well. And there should also be a history of asthma, which is absent in this case. Okay, so that's our provisional diagnosis, Goodpasture syndrome. And let's talk about some important points about um, um, let's talk about some important points of this disease. Obviously, it's common in adult males who tends to be smoker. There might be a relationship between smoking and the disease because it's exclusively present in smokers. And the pathophysiology involves formation of antibodies, and those antibodies are actually directed against type 4 collagen. You remember that there are four types of collagen: type 1, 2, 3, and 4. And the type 4 collagen are commonly found in the basement membrane. And this basement membrane may be present in the lung or in the kidney. So the antibodies actually bind to the basement membranes of the alveoli and also of the glomerulus. So there are two sites of antibody attachment, formation of antigen antibody complex, which leads to activation of other inflammatory systems, including complement activation and neutrophil activation. And as the patient has inflammation in the pulmonary alveoli, the patient develops some pulmonary symptoms such as shortness of breath, hemoptysis, and hemoptysis especially occurs due to bleeding or pulmonary hemorrhage, and typically lung involvement is earlier than a renal involvement. This is the case uh, in our This is also true for our case that we have already presented, as the patient had cough and shortness of breath, hemoptysis for 2 weeks, followed by renal involvement for the last 2 days. So the lung involvement is before and the renal involvement is after. The renal findings are due to glomerulonephritis. So whenever there is glomerulonephritis, there will be leakage of protein and RBC. So there will be proteinuria, which is nephritic range, or small or moderate amount. And obviously, whenever there is glomerulonephritis, there is damage to the glomerular apparatus. So filtration will be decreased. So there would be oliguria, or decreased production of urine, and might be anuria in advanced cases, meaning that the patient develops acute kidney injury. And we have already mentioned about the hematuria. As the patient develops glomerulonephritis, it leaks out RBC through the glomerular apparatus, which goes to the basement, goes to the Bowman's capsule, ultimately becomes dysmorphed and sometimes forms pus. And if we want to do one test only, especially if we are told to do one test just before everything else, that test would be anti-glomerular membrane antibodies. This is very easy to be done, and it's often very highly sensitive and specific. But if we are told to answer what's the best test, not best initial test, what's the best test or what's the most accurate test, it would be a biopsy. So it would be a biopsy from lungs or kidney, and it should be coupled with immunofluorescence. And if we do a renal biopsy, we would see crescents. So it would be a crescentic glomerulonephritis, which is often known as RPGN, or rapidly progressing glomerulonephritis, a very rapid form of glomerulonephritis where the renal function deteriorates within a very short period of time and the patient might die. And if we do immunofluorescence from the biopsy specimen, we'll be able to recognize the antibody, as it will be in the membrane in a linear pattern. So there will be linear IgG deposition along the glomerular basement membrane. It's a beautiful picture, although this test costs a lot. So this is a gross biopsy specimen from patient, and if we want to highlight the important features, so those are the tubules. Okay, tubules. This is a glomerulus. So not a single glomerulus actually. This is a area with Bowman's capsule, and those are the glomerular capillaries. So those are the glomerular capillaries, and this is actually a crescent. So this is a crescent. If we want to highlight in another color, we can do that by this way. So this is a crescent, or moon-shaped deposit or area of inflammatory exudate and cells. So there has been excessive inflammation in the glomerular area, which led to deposition of fibrinoid material and exudates and cells in the Bowman's capsule, leading to a crescentic structure. This is actually very important for us to identify because it's a bad prognostic sign, and probably this patient would require dialysis in an emergency basis. And this is the immunofluorescence picture. If we want to see what's going on, this is the biopsy specimen, obviously, and those are the areas with immunofluorescence. The green color is the fluorescence, and we can see those are tubules, and those are the areas with glomerular capillaries. So Bowman's space, Bowman's membrane, Bowman's space, and the glomerulus. So those are the glomerulus, and we can see that the glomerulus actually has a linear pattern of immunofluorescence. The green color if we want to focus on upper part, the green color is distributed in a linear pattern. So there is a linear pattern of distribution of the greenish color, and the greenish color occurs. The greenish color is due to the reaction of antigen antibody complex, which gave off this beautiful combination or this beautiful view. It's a very beautiful picture that you can see that linear IgG immunofluorescence. If we want to zoom in and want to see a better picture, this would be the one. And you can see that this is the Bowman's capsule with the Bowman's space inside, and in the center there are some glomerulus which are highlighted. This is probably from a kid as the patient's glomerulus number is low, but you can easily see the important distribution, which is the linear distribution of the fluorescence, the linear distribution of fluorescence, and those are actually IgG antibodies. Okay, that's a beautiful picture. And if we summarize Goodpasture syndrome presentation, antibody formation, pulmonary hemorrhage, and RPGN. And the treatment is fairly obvious as this is a disease where antibody formation happens. We have to prevent the formation of antibody, so we have to suppress the immune system, for which we need corticosteroids, obviously high dose, and cyclophosphamide. So they will decrease the level of immunoglobulin G. So this is one part of treatment. And another part of treatment is plasma exchange or plasmapheresis. This is done when patients develop RPGN or the patient has severe pulmonary disease. And the reason or the mechanism by which they work is they remove the IgG from the blood. So you are cleaning the blood and the IgGs are taken out from the body. Obviously, this improves the patient's condition. And most of the patients require dialysis. Okay, so that is all okay. Okay, now let's talk about Wegener Granulomatosis. Sorry for the multiple repetitions, or sorry for the repetitions. There is an interesting story behind the naming of this disease. Wegener, Mr. Wegener, was a German pathologist who lived until probably 1990. But sadly, he was a member of German Nazi Party during Second World War. And that is why many of the scientists actually questioned the name. So most of the British and French scientists were not happy with that name because he was associated with a dark chapter of the history. So this disease was renamed with granulomatosis with polyangiitis. This disease was renamed as granulomatosis with polyangiitis. So this is a nice name because it depicts the important pathophysiology underlying the disease. So there is formation of granuloma in multiple vessels, okay, granulomatosis and with polyangiitis. And this inflammation is actually a necrotizing inflammation. And this involves polyangiitis is vasculitis. This involves mainly small vessels and sometimes medium-sized vessels. So if we summarize the pathophysiology, there is extensive necrotizing inflammation of small vessels, which sometimes leads to formation of granuloma. So if I repeat that, extensive necrotizing inflammation of small and medium-sized vessel, which sometimes leads to formation of granuloma. Okay, so it's a granulomatous disease. And the common involvement happens in the upper respiratory tract as well lungs and kidneys. So it's also a pulmonary renal syndrome. And the upper airway disease is a distinguishing feature because presence or absence of these might help us to differentiate between Wegener's versus Goodpasture syndrome. And there may be involvement of nose, ear, and sinuses. And the nose involvement typically leads to some inflammation in the nose. So inflammation might lead to obstruction or discharge and sometimes formation of crust, which ultimately can lead to ulcers and epistaxis. And if the inflammation is prolonged and the ulcer is extensive, then there will be destruction of nasal septum, which will lead to a deformity known as saddle nose. The ear involvement can lead to inflammation in multiple parts of the external middle and internal ear. So if middle ear inflammation occurs, we call it otitis media. Mastocytitis can also happen, and deafness can happen due to involvement of the inner ear. Sinusitis is also a very common finding in patients with Wegener's granulomatosis. Now let's respect the British and French physicians and only say the name as granulomatosis with polyangiitis. Beautiful name. The pulmonary involvement or lung involvement is typically manifested as cough and hemoptysis. Obviously, there are similarities between Goodpasture and this disease. Both of them presents with hemoptysis, and which can be very severe. The renal disease is similar with inflammation of the glomerulus, so glomerulonephritis, which may be a rapidly progressive variety. And whenever there is RPGN, there will be formation of crescent, as we have seen previously. And obviously, there would be protein leak and hematuria. Eye involvement is and different. Eye involvement is a special finding for this disease, as the patient can have inflammation in and around the ocular apparatus. So, if the inflammation happens in retroorbital tissue, then there will be proptosis and deposition of some inflammatory debris and exudates in the retroorbital space might entrap the extraocular muscles, and if extraocular muscles cannot work properly, the patient would develop diplopia, so double vision. And if the optic nerve is involved, there will be loss of vision, and at the early stages we would see that there is loss of color vision. This is actually similar to multiple sclerosis, where we have retrobulbar neuritis, and the retrobulbar neuritis actually leads to loss of color vision at the beginning. So this is the beginning of inflammation around the optic nerve. And there are some other common uh, complications in the eye, including inflammation in various parts. There are some other features, as all the vessels in and around the body are involved. So there might be skin purpura, peripheral neuropathy, mononeuritis multiplex, and arthralgia. I think mononeuritis multiplex is an important feature to remember. It means that involvement of single nerve, so mononeuritis, single nerve inflammation, multiplex in multiple locations. So multiple nerves such as involvement of ulnar, median, or sciatic nerves can be present in patients with this disease. Here is a picture of a patient who developed Wegener's granulomatosis and now is suffering from a complication. And the patient, if we compare the right eye with the left eye, would see that there is proptosis of the left eye and there is inflammation and edema surrounding the extraorbital tissue. So probably the patient had developed severe inflammation around the retroorbital space, which actually caused compression behind the eye, leading to proptosis, and also there is an extensive inflammation. Now let's talk about the test. Obviously, the most specific and the best initial test would be a C-ANCA. C-ANCA means cytoplasmic anti-neutrophil cytoplasmic antibody. and this is directed against a protein which is an enzyme. This is known as proteinase 3. This is a very specific test for Wegener's granulomatosis. But the most accurate test would be a biopsy. Mm, Best to take it from lungs, although we are doing renal biopsy more often. But biopsy from upper airway can also be taken. But the problem is they are less accurate. Here we can see immunofluorescence of the anchor. This is the C anchor, and you can see this is the nucleus of the neutrophil. This is the neutrophil. This is the neutrophil. This is the neutrophil, and this is the neutrophil. I can see the three lobes of the neutrophil nucleus. So this is the trilobe nucleus. This is the bilobe nucleus. So those are the nucleus, and the green color is present in the cytoplasm. So you can see the green color in and around the nucleus in the cytoplasm. So the cytoplasm contains those green colors. So the antibodies are present in the cytoplasm and they are spread across the whole area of cytoplasm. That's why we are calling it a C-ANCA, cytoplasmic anti-neutrophil cytoplasmic antibody. There is another variety of ANCA, which is P-ANCA, and in case of P-ANCA, this green color would be present mainly surrounding the nucleus rather than being spread across the cytoplasm. There are some other tests which are also needed to be done. And if we want to see the activity level of the disease, we'll be doing the ESR or CRP, and the WBC count is obviously would be high. And antibody levels also give us an idea about the activity. Urinalysis would obviously show active sediment, and chest X-ray might show nodules and cavitation. Would come about that or talk about that. And the CT scan would also show the same things, which is cavitation and sometimes alveolar hemorrhage. This is an interesting chest X-ray. As you can see that in the lung fields, there are multiple nodules and cavity relations. So if we want to find them out, this is a nodule, this is another nodule, nodule. So many nodules. Also here and here and here. As it appears, this might be misleading. Someone might consider this is a case of cannonball shadows, which indicates multiple metastasis to lungs. Yes, might be. You never know. And there is also a cavity relation in the left midzone. So in this X-ray, we're having multiple nodules and cavity relations in bilateral lung fields. So the differential would be multiple metastasis, might be other disease like pulmonary abscess, so multiple lung abscess, and obviously our disease, which is granulomatosis with polyangiitis. The CT scan would differentiate some of those features, and you can see the similar findings in the CT scan, such as nodules here, and also here, and also here. And one of the cavity relations are depicted very well in the posterior zone of the left lung. Obviously, this is the heart, and obviously, this is the left heart, left ventricle, the right ventricle, the aorta. Okay, and let's come to the treatment. The treatment depends on the severity of the disease, and if we are dealing with a severe disease, it would require active and emergency management with high-dose steroid and cyclophosphamide. And if the patient is able, especially economically able, we might consider adding rituximab, which is also a good drug that can produce remission. And the steroid would include primarily methylprednisolone, but later on we'll switch to oral, and also cyclophosphamide at a high dose of up to 1 gram every 2 weeks for at least 3 months. And the maintenance requires other immunosuppressive agents at a lower dose, including steroids, azathioprine, methotrexate, and sometimes we can replace it with mycophenolate mofetil. And here are the indications of plasma exchange or plasmapheresis, by which we want to take out the antibodies. Obviously, this is a procedure which is one of the last resorts for us, and it's also very expensive. And we consider it when someone has an extensive or aggressive disease, such as renal disease with a high creatinine level, and if the patient has pulmonary disease, which is very severe. Those are the conditions where we would opt for this kind of treatment. And if the patient has renal disease, we would also consider having dialysis, preferably hemodialysis. And we sometimes add antibiotics to prevent infection, such as pneumocystis and staphylococcal infection. Now, let's talk about Churg-Strauss syndrome within a very short time. This is a similar vasculitis, which is a granulomatous vasculitis, and there are pulmonary infiltrates. The differentiating point here are asthma attacks and eosinophilia. So those are the 2 points that we would always look for to identify someone with Churg-Strauss syndrome. And as it is a vasculitis, it would involve multiple systems, including skin, muscle, and sometimes nerve lesions, just like Wegener's. The best initial test would be a Pianka as opposed to Cianca in Wegener's. So Pianka in Churg-Strauss. This is elaborated as perinuclear anti-neutrophil cytoplasmic antibody. It's also known as anti-myeloperoxidase or anti-MPO. MPO here means myeloperoxidase. It's an enzyme present in neutrophil. But the most accurate test would be a biopsy. And this pattern is seen for all the 3 diseases that we are talking today. For all of the tests, for all of the disease, the best test is an antibody test. Sorry, the best initial test is an antibody test, but the best, let's rephrase it. The best initial test for all of the disease is an antibody test, but the most accurate test is a biopsy. And the treatment is similar with systemic glucocorticoids and cyclophosphamide. Okay, that's the end of the basic discussion. And if we want to summarize our findings, we would first talk about Goodpasture. This is a pulmonary renal syndrome which does not have upper respiratory tract disease. Wegener's. This is also a pulmonary renal syndrome, but it also involves upper respiratory tract and other systems, especially nervous system. Churg-Strauss syndrome is a disease which is a pulmonary renal syndrome, but it has asthma and eosinophilia. So those would be our take-home message. And if we consider the investigations, the best initial test is an antibody test. For Goodpasture, it's an anti-GBM antibody. For Wegener's, it's Cianca. For Churg-Strauss, it is Pianka. But the best test is a biopsy. For Goodpasture, a renal biopsy. For Wegener's, lung biopsy, or if not possible, then renal biopsy. And for Churg-Strauss syndrome, a biopsy from either lungs or kidney. The treatment are similar. For all 3 diseases, we would have steroids and cyclophosphamide to induce remission. But in aggressive disease, especially Goodpasture and Wegener's, would require plasmapheresis and renal dialysis or hemodialysis. So those are the important points that you must remember when answering a question or dealing with a patient in your clinic. That's the end of presentation. Thank you very much for watching. Please like and subscribe to my channel and recommend what are the other topics that I should make videos on. Thank you very much.